This is the final tutorial on mechanisms of hypoxemia, and I'm going to discuss lung volumes and why lung volumes are important, and in particular why low lung volumes are bad. I'm going to focus on one volume in particular, functional residual capacity. You cannot understand mechanical ventilation unless you understand the importance of functional residual capacity in physiology and in medicine. Tutorial 18. Hypoxic respiratory failure, Part 7. Why low lung volumes are bad. Welcome back. Previously we looked at high flow oxygen therapy. We looked at active versus draw over flow. We looked at high flow oxygen systems and how they work and how they are believed to work. I talked about the initial approach to high flow oxygen therapy and the clinical indications and contraindications to high flow oxygen therapy. This time I will discuss lung volumes, functional residual capacity and why it's so important, airway closure and closing volume, and dynamic airway collapse. Let's start with a clinical scenario. You are called to the high dependency unit or the ICU to see Peadar. He's a 67-year-old male. He's 5 days post esophagectomy, and you are told that he saturates 96% when sitting up, but desaturates down to the 80s when lying down. What's going on here? To understand this, we need to start by looking at lung volumes and lung capacities, and this requires a graph. This will be a familiar picture if you've ever looked at a physiology textbook, but there's a slight difference in this particular version of the lung volume graph in that I've put the lung volumes on the y-axis in mils per kilo of ideal body weight, and there is a good reason for this. Your lung size is related to your height, not your girth. A 5'9" or 175 centimeter slender person has the same size lungs as an obese individual or a bodybuilder of the same height. So we're going to start at the resting lung volume here. This is it here, and this is the volume of gas that's in your lung at end expiration, and that is 30 mils per kilo. And when you take a breath, you take a tidal breath, tidal volume of about 7 mils per kilo. That means that at the end of normal inspiration, there's about 37 mils per kilo of gas in the lungs. Now there's more space in the lungs. In fact, there's twice as much space in the lungs as you have already used. And if you take a huge, big, deep breath in, you can get in about 43 mils per kilo of additional air into the lungs. And this additional volume is known as the inspiratory reserve volume. And as I've mentioned, it's really hard to hold that in your lungs. You have this tremendous urge to exhale. Now, when you exhale down to the resting lung volume, you start all over again. And what we're going to do is we're going to get our patient to exhale as hard as they can, and they will exhale out approximately 15 mils per kilo until they can't get any more gas out. So roughly twice as much gas can be pushed out of the lungs at the end of a normal tidal volume than you normally take in a tidal volume. And this is the expiratory reserve volume. And what's left in the lungs at the end of that is the residual volume. And that is also about 15 mils per kilo. So if you add up the residual volume and the expiratory reserve volume, you get the functional residual capacity, that resting lung volume of 30 mils per kilo. Above the FRC is the inspiratory capacity, and that is 50 mils per kilo. And if you add the inspiratory capacity to the functional residual capacity, you get the total lung capacity, and that is 80 mils per kilo. So let's look at the numbers for a patient who is 70 kilos, 5'9" or 175 centimeters. Well, in this case, the total lung capacity will be 5.6 litres, tidal volume about 500 mils, that's rounded up. The inspiratory reserve volume around 3,000 mils, 3 litres. The expiratory reserve volume of just over a litre. The residual volume is exactly the same, just over a litre. And the functional residual capacity is 2,100 mils. Now that we have an overview of the different lung volumes, let's look more specifically at the volumes in each one of the lungs and its subdivisions. I think this is important, particularly if you're working in ICU. So this is an overview of the lungs, and you'll recognize there's two lungs, a right lung, a left lung. In the middle you have the trachea and the bronchial tree. There are 5 lung lobes. The right lung has 3 lobes. It has a right upper lobe, a right middle lobe, and a lower lobe known as the right lower lobe. The left lung has 2 lobes, the left upper lobe and the left lower lobe. Now it's important, even when you just look at these pictures, to understand that when the patient is facing you or they're lying down, the front of the chest is represented mostly by the upper lobes and the right middle lobe. If you turn the patient around and look at the back of their chest, most of what you're looking at, and indeed if you auscultate, what you're listening to, is the lower lobes. The lower lobes are in the posterior part of the chest. The upper lobes and the right middle lobe are in the anterior part of the chest. The following are data from an excellent study of Japanese volunteers whose lung volumes were measured by computed tomography, that's CT, and they had CTs in the erect and supine and sitting positions. And this was achieved by having specific CT scanners that could actually scan the chest, in whether the patient was standing or lying down or sitting, and they asked the patients to take a deep breath in, scan them, and then to exhale, and then they scan them again. So we have some really good information now about what patients' lung volumes are like in inspiration and in expiration, keeping in mind, of course, that these are only subjective. In other words, this wasn't the absolute maximum inspiration or the maximum absolute expiration. And I do think the expiratory values may be just a little bit high to represent functional residual capacity. The table that you're looking at here represents these Japanese individuals. 70% of them were women, and the median height was just over 161 centimeters, or 5 feet 3 inches tall. And these are significantly smaller people than the average European, American, or Australian who might be listening or watching this video. And as a consequence of this, I have scaled up these data to a 180 centimeter male. That's the mean height essentially for Americans, Australians, and Europeans. And so these are the data for the Europeans, and I'm going to present this in a slightly different way than the table, just to make it easier to understand. This is a graphical representation of what's going on in the lungs. Now, you'll recall that when I introduced this particular paper, I mentioned 3 different positions: sitting, standing, and lying flat in the supine position. But when I looked at the paper, I realized there really wasn't a lot of difference in lung volumes between standing and sitting. So I've lumped them together under the term erect. And when patients were erect and asked to take a deep breath in, they were able to achieve, on average, a total volume of 5,500 mils, divided into the right and left lungs. The right lung was 3,000 mils, the left lung was 2,500 mils. Remember, these are being read on CT and volume analysed. Right upper lobe, 1 litre, right middle lobe, half a litre, right lower lobe, 1,500 mils, left upper lobe, 1,200 mils, and left lower lobe, 1,300 mils. Obviously, the first thing you want to do when you take a deep breath in is exhale. Now, these patients exhaled and they were scanned again. And of course, there was a dramatic drop in volume. We know from the volumetric analysis I showed you earlier on that the inspiratory reserve volume is about 47%. So the fall off here was slightly lower than expected. It was about 40%. So I don't really believe that the volume that they've given us in expiration is the real FRC. The volume fell down to 3,300 mils, and there was a loss of volume throughout the different lung lobes. What I found particularly interesting, though, is the major loss of volume from deep inspiration to expiration was from the lower lobes of the lungs. So when you take a deep breath in, it's the lower lobes that you recruit, and when you breathe out, it's the lower lobes that you lose volume from. What I'm going to look at here is the difference between the supine position in inspiration and then the supine position in expiration versus the erect versions. So when patients lay flat and they took a deep breath in, they weren't able to really achieve the same tidal volumes as they could while they were erect. The right lung volume was 2,500 mils, the left lung volume was 2,200 mils, for a total volume of 4,700 mils. And compared to the erect position here, that was about 15% less. And the major loss of volume here was principally in the lower lobes again. So when you take a deep breath in, you lose volume principally when you exhale from the lower lobes, and when you lie flat and take a big deep breath in, the loss of volume versus the erect position is mostly in the lower lobes. When patients are lying flat in expiration, they lose even more volume, and the supine expiratory volume was 3,000 mils in total, 1,600 mils in the right lung, 1,400 mils in the left lung, and the right upper lobe was 600 mils, right middle lobe 300 mils, right lower lobe 700 mils, left upper lobe 800, and left lower lobe 600. And the changes from erect expiration were interesting. So the biggest effect was on the right lung versus the left lung. Remember, the right lung is a bigger lung than the left lung. And the right upper lobe lost 15%, right middle lobe no change, and about 11% in the right lower lobe. The left upper lobe, there was virtually no change in expiration compared to being erect. So it's strange, you get this big loss of volume from the right upper lobe when you lie down, but not from the left upper lobe. Big loss though from the left lower lobe. So the overall loss of volume from being erect to lying flat was about 10%, but the biggest effect was on the right upper lobe and the left lower lobe. What about the prone position? Well, the prone position we all know improves oxygenation, but it doesn't do so by recruiting lung. And if you look at multiple studies done over decades that have done volumetric analysis of the lungs, the lung volume is more or less the same in the prone position as it is in the supine position. So when we looked at this erect versus supine position, we can summarize it as follows. You lose about 10% in lung volume in end expiration when you go from erect to supine. So if you have a hypoxemic patient, by lying them flat, you're going to lose lung volume and you're going to worsen oxygenation. The loss of volume is principally in the lower lobes. Expiratory lung volumes are approximately 40% lower than inspiratory lung volumes, and that is our inspiratory reserve. And we can call on that using mechanical ventilation, using some sophisticated techniques. And you should never forget that those volumes are there. Now let's move on and look at ventilation perfusion mismatch and functional residual capacity. We've looked at ventilation perfusion relationships in the normal lung in the erect position, and as you can see, lung volumes are very low in the posterior dorsal segments of the lungs at end expiration, but they ventilate very well, so they get quite big as ventilation goes on during the normal tidal breath, such that there's quite good uniform distribution of air at the end of the tidal breath. But the lung units in the anterior apical segments are relatively less ventilated than those in the bases. And of course, blood flow follows gravity, and the best perfused part of the lung is those posterior dorsal segments. Consequently, the bottoms and backs of the lungs, so if you're standing behind your patient, it's those bases of the lungs in the posterior dorsal segments are best ventilated and best perfused. The midzones are moderately well ventilated and moderately well perfused, and the anterior apical segments have relatively low ventilation and relatively low perfusion. The chest wall has a tendency to spring outward, so it's like it's ratcheted down and it wants to move in an outward and upward direction. This is balanced by the tendency of the lungs to collapse inwards on themselves. So chest wall wants to spring out, the lungs want to collapse in, and what counterbalances these two effects is the negative pleural pressure. The chest wall is lined by the parietal pleura, the lungs are lined by the visceral pleura, and these tug apart and there is a negative pressure between the two. The highest negative pressure, because of gravity, is in the anterior apical segments of the lungs. The lowest pressure is adjacent to the posterior dorsal segments of the lungs. On this cartoon, I'm going to draw the pleural space here. So there's the pleural space there, and the pleural pressure in this example is -5 centimeters of water. Now, if a clinician comes along and attempts to, for example, insert a central line and perforates a pleura, immediately what happens is that gas will be drawn in along that pressure gradient from atmospheric pressure in the room into the negative pressure within the pleura, and that air just rushes in through that hole, that defect in the chest wall, and the defect in the pleura, and that pleural space will fill with air until the pressure within the pleura is the same as the atmospheric pressure. And what you see if you look at an x-ray of someone with a pneumothorax is the chest wall springs further outwards and the lung collapses inwards. And that will explain to you what would actually happen if we didn't have this balancing force between the outward spring of the chest wall and the inward collapse of the lungs. And this is a chest x-ray of a pneumothorax, and the arrow represents the edge of the lung. And you can see how far it is from the chest wall. This is the trachea, which is deviated to the right in this particular patient, and the heart is also pushed rightwards, and this is a tension pneumothorax. Why this is important is because the lung volume, where the tendency of the chest to spring outwards is balanced by the tendency of the lung to collapse inwards, and the pleural pressure in between is known as the functional residual capacity. The functional residual capacity, therefore, is the resting state of the lungs. It's where breaths start. It represents 30 to 35 mils per kilo of ideal body weight. Let's look at expiration versus inspiration versus time. You can see here that inspiration is very, very short in the average minute. In any given minute, only about 10 seconds and probably significantly less is spent in inspiration. And why is that important? Because people have this idea that inspiration is all about gas movement, but that's not true. Inspiration, that tidal ventilation, is about ventilation. It's about getting rid of carbon dioxide. Nearly all gas exchange occurs during expiration. And the end expiratory lung volume is the functional residual capacity. It is the resting lung volume, which means that as most time is spent in expiration, most gas exchange occurs at functional residual capacity. It is the key lung volume. How much is it? Well, it's 30 to 35 mils per kilo. And I've just put this table up here so that you can pause on this and have a look at different heights and sizes of your patients or volunteers. The part of the world that I live in, the average female is 5 feet 6 inches tall, or 168 centimeters, and that translates to an FRC of between 1900 and 2250 mils, around 2 liters of FRC. For the average male, it's 5'9" or 175 centimeters. The FRC is 2,200 to 2,500 mils. So if we have a patient with an FRC of 2,250 mils and a tidal ventilation of 550 mils, well, how much oxygen is in the lungs? Well, we'll start off at end expiration, where we have our end expiratory lung volume. That translates to about 450 mils of oxygen in the lungs at end expiration. At end inspiration, there is about 550 mils of oxygen. But remember, most of the time it's the 450 mils that actually matters. So FRC is the body's oxygen reservoir. It's what's there when you stop breathing, which is most of the time. It is the volume of gas within the lungs from which most of the oxygen is drawn for homeostasis. As a consequence, if FRC falls, that is, if lung volumes fall, then less oxygen is available for gas exchange. Well, what happens when there is atelectasis of, for example, 30%? Remembering what's in the alveoli is 20% oxygen and 79% nitrogen. So when 30% of your resting lung volume is lost, then the oxygen content falls dramatically. And in this case, it will fall from 450 mils down to 300 mils. That seriously shortens the non-hypoxic apnea duration, and it doesn't even account for the problem of airway closure. I'm going to revisit airway closure for a minute. As you will recall, gas always diffuses from where it's in high concentration to where it's in lower concentration. In this cartoon, the green arrows represent oxygen. And this is what normal ventilation perfusion looks like. Note there is an approximate alveolar to venous oxygen difference of 70 millimeters of mercury or 9.5 kilopascals and an alveolar to arterial difference of 10 millimeters of mercury or 1.5 kilopascals. So oxygen continues to diffuse along that gradient. The key thing to understand here is that as oxygen is taken up from the alveoli, the alveolar oxygen concentration falls and an oxygen gradient between the conducting airways and the alveoli is created. So gas continues to diffuse from the anatomical dead space into the alveoli during the expiratory phase of the respiratory cycle. Remember that gas exchange occurs continuously both in inspiration and expiration. Let's change the situation around. As we age, the elasticity of our lung changes, such as the conducting airways are not always patent during expiration. This is known as airway closure. It also occurs with lung disease. When airway closure occurs during expiration, there is failure to replenish gas from above, and gas within the alveoli becomes stale and the alveolar volume falls. This causes venous admixture and hypoxemia. Airway closure occurs between functional residual capacity and residual volume. The volume between FRC and residual volume in which closure occurs is known as the closing volume, and the closing volume plus the residual volume is known as the closing capacity. Closing capacity increases with age. By the age of 45, closing capacity is equal to FRC in the supine position. By the age of 65, closing capacity is equal to FRC in the upright position. The residual volume increases progressively with age. This functional airway obstruction significantly contributes to abnormalities of perioperative gas exchange, and it is a huge problem when elderly people develop pneumonia or other lung diseases. This leads me to a critical element in this tutorial that I want you to remember and understand when we move on to look at severe lung injuries. When there is lung disease due to slimy, sticky, soggy lungs, etc., there is atelectasis. There's also gravitational loss of lung volume and airway closure. All of these are problematic in exhalation and lung volumes are low. So you can see here now we have a picture of exhalation. We have an atelectatic lung unit. We have some partially inflated lung units that are closed, and then we have some normal lung units. During inspiration, gas exchange is relatively normal because all of these lung units recruit, and during expiration, the gas exchange is poor. I call this phasic shunting. Typically, this does not respond to standard oxygen therapy. You have to keep those lung units recruited during exhalation. You have to restore functional residual capacity. In the next tutorial, we will look at how you do that. All of the elements in health and disease results in early airway closure with age and increased shunt from less than 5% of cardiac output in your 20s up to 7 or 8% in your 70s. There is a significant increase in venous admixture due to the phasic nature of airway closure. And the combination of the two results in older people having a lot of ventilation perfusion mismatch that increases with age up to nearly 15% of cardiac output. The other thing, and it's really important to understand, is that when your patient comes into hospital, whether they're having anesthesia or they're acutely ill, their position really matters. Functional residual capacity is not fixed. In this cartoon, you will see the FRC volume in liters on the y-axis, and this is for a typical patient. If the patient is positioned head down in the Trendelenburg position, the FRC is at its lowest. So here it is at around 2 liters in this particular patient. Now we're going to start tilting the patient. But when would you encounter a patient in this position? Well, a lot of modern laparoscopic surgery is performed in this position. Robotic prostatectomies, robotic assisted cystectomies, some of the laparoscopic colectomies. The patient are in this head down position and they lose a significant amount of resting lung volume in this position. When you lie them flat, as I've pointed out before, the FRC rises a little bit from that very extreme position, but this is normally the lowest FRC you will encounter in your patient while they're in the hospital. Tilting them up to 30 degrees head up significantly improves FRC. Going up to 60%, you've got a further improvement. And if you stand the patient up, you get to the absolute maximum functional residual capacity that you can get at. And just look at the difference there. From the worst position, the Trendelenburg position, to standing, there is a 1 liter or 50% improvement in FRC. Now it dips a little bit in the seated position or the head elevated position, but not a whole lot. And this is the position that we put our patients in the ICU, and they have pretty optimal FRC in this position. And it's one of the very, very strong arguments for, and there's lots of other ones such as reducing the risk of gastropulmonary aspiration, but lung mechanics are best in the erect position. And the more erect the patients are, the better. And it's really much easier to nurse a patient who's semi-erect than obviously standing up. So look at these lines, how they all intersect and where the best position is for optimal FRC. This is our first visit to the volume pressure curve. On the y-axis is the tidal volume in mils, and on the x-axis is the airway pressure in centimeters of water. When the patient takes a breath, they have to generate negative pleural pressure to open up the airways and lift the chest wall off the lungs. When the patient exhales, the lung volume is slightly higher per unit airway pressure in exhalation, and this is a process known as hysteresis. Although lots of people talk about hysteresis, and it's in all of the textbooks and everyone makes a big deal about this as a concept, I find it of minimal clinical relevance. A key component to viewing the volume pressure curve is to determine how easy it is vis-a-vis the driving pressure to inflate the lung, and we call this the lung compliance. Of course, measuring individual lung compliance is very tricky at the bedside in ICU, so when we look at the compliance figure that is presented by the ventilator, it is the total respiratory system compliance that is measured. We also tend to measure it dynamically, meaning during an active breath when the machine is driving gas into the patient's lung, rather than statically where the patient must be paralyzed and measurements made sequentially with a super syringe. You may be familiar with the super syringe static concept from research, but most people do not do this in clinical practice. To calculate the dynamic compliance of the respiratory system, you need 3 numbers: the PEEP, the peak pressure, and the tidal volume. So the calculation is as follows. the tidal volume in mils is divided by the peak minus the plateau pressure in centimeters of water. So we end up with a number, the compliance number, in mils per centimeter of water. If the PEEP is 5 centimeters of water and the peak pressure is 20, the tidal volume is 500 mils, what is the dynamic compliance? Well, this works out at 500 divided by 20 minus 5, which is 15, and 500 divided by 15 is 33 mils per centimeter of water. I will tell you that that is not a great compliance. Really compliant lungs, totally normal lungs, are about 200 mils per centimeter of water, but typically someone who's on a ventilator in the ICU breathing through an endotracheal tube, anything over 60 or 70 mils per centimeter of water we would consider relatively normal. Compliance is optimal at functional residual capacity, and so too is airway resistance. This is a volume pressure curve for a normal person at normal FRC. Recall that the anterior apical segments of the lungs are the most inflated components at end exhalation. They inflate little with tidal breaths, so they appear on the flat part of the volume pressure curve. They are poorly compliant. In the middle zones, the lungs are moderately compliant, and in the bases, the lung units are highly compliant. They inflate well and they ventilate well. However, this is not always the case. This is a simple cartoon of a single lung unit at end expiration. That zero there represents atmospheric pressure. In medicine, we generally refer to atmospheric pressure as the baseline airway pressure, and we're positive or negative above that. So zero is atmospheric pressure. These are the conducting airways. This is the alveolus or alveoli, and this is the pleura, and that number there is the pleural pressure. It's a negative pressure currently. The transpulmonary pressure is the alveolar pressure minus the pleural pressure, and in this situation, the alveolar pressure is 0 and the pleural pressure is -5. So 0 minus -5 gives you a transpulmonary pressure of +5. Now, when the patient inspires, they generate a negative pressure that is greater than the resting negative pressure in the pleura. And this sucks open the alveoli and generates a negative pressure within the alveoli. And that negative pressure passes all the way along the conducting airways, all the way out to the mouth, where the airway pressure is 0. And once the glottis opens, gas flows along that pressure gradient. So this is what happens in early inspiration. And you can see here that the transpulmonary pressure is +4. At end inspiration, we are in a situation where the pleura are fully expanded. So we have opened up the chest pump as much as we can by the diaphragm descending and generating all this negative pressure within the pleura. But the gas in the alveoli has completely equalized with atmospheric pressure. So at end inspiration, the pressure within the alveoli is 0 and with respect to atmospheric pressure, and it's 0 all the way along the conducting airways. Expiration is a passive process. There is elastic recoil of the chest where the diaphragm relaxes and everything presses in. And as a consequence, the pleural pressure drops, and this essentially pushes down on alveoli that are full of gas, and those alveoli generate a positive pressure with respect to atmospheric pressure, and that causes a chain of positive pressure to run all the way along to the mouth, and gas flows out those airways. And this all keeps on going on until the airway pressures are all equalized at atmospheric. And that's really what happens when we get to FRC. But if you don't get to FRC, if you go beyond that, if lungs collapse down as we have seen, and we lose our volumes, or there is gas trapped due to bronchospasm, for example, or due to crud in the airways, or for any reason that there is trouble expelling gas, or there is forced expiration, you have this problem where the pleural pressure may be very high and the gas generates a positive pressure within the alveoli, but it doesn't continue all the way out to atmospheric pressure. So the pressure outside in the pleura is higher than the pressure within the airways. There is dynamic compression of these airways, and gas gets trapped in the alveoli, and this causes the problem of auto PEEP. When you see this in clinical practice, it can be really problematic because you can see patients gasping for air, but they generally have very hyperinflated chests when you see them in the emergency room. That's usually during COPD or during acute severe asthma. Sometimes you see it with high levels of PEEP. But you can also see it in low lung volume situations where the chest wall compliance is lost because the patient's really edematous, or they have intra-abdominal hypertension, or there's something going on that they cannot expand their lungs. So the lung volumes fall, the intrapleural pressures get higher, and gas gets stuck in the alveoli at end expiration. Plotting all of this on the volume pressure curve will help you make sense of what's going on in the lungs of patients at low FRC. And the first thing that you will notice on the graph here on the right hand side is how that volume pressure curve now has been pushed leftwards. There is positive pressure in the pleura in the posterior dorsal segments of the lungs. So that negative pressure that sucks open alveoli, particularly during expiration, is not there. And so there's a tendency for these lung units to collapse or have dynamic airway compression. You can see here there's airway closure, there's secretions, there's slimy stuff within the lung units. As a consequence, the lung units in the mid zones have positive pressure in relation to atmospheric pressure, and in the posterior dorsal segments that pressure may be quite high. And the only lung units that we can see here that are sit at atmospheric pressure at end expiration are on the anterior apical segments of the lungs. And as a consequence of all of this, those lung units are now on the steep part of the volume pressure curve. And so they will ventilate very well, gas will go in, and those lung units will open up really well, and there'll be lots of ventilation. But the lung units in the mid zones and the lower zones will be on the very flat part of the curve, and they may actually have gas trapped inside, so there may be positive pressure in there. And so the pleural pressure outside of this area, it may be zero, it may be positive, but with gas trapped under positive pressure inside these alveoli, the amount of effort it requires to get gas into these lung units is very high, because the pleural pressure must be very negative to overcome the positive pressure of trapped gas. And we will discuss this in detail in the next tutorial. One final thing that I want to mention at functional residual capacity is vascular resistance. Vascular resistance is lowest at functional residual capacity. This is the resting state of the lungs. If lung volumes become lower, there is vasoconstriction, principally caused by hypoxemia, but also because of compression, and vascular resistance increases. But also, if lung volumes increase, and if you increase lung volumes all the way towards total lung capacity, you'll see this, then vascular resistance increases as well due to stretch. So to summarize all of this, the functional residual capacity is our oxygen reservoir. It provides oxygen during expiration. It is the point of optimal lung compliance. It is the point of lowest small airway resistance. It is the point of optimal pulmonary vascular resistance. Functional residual capacity is reduced in the supine and Trendelenburg or head down position. It is optimal in the erect and sitting positions. As we age, there isn't a lot of change in FRC, but residual volume increases. This results in increased airway closure with stale gas in the alveoli, causing venous admixture. Airway closure occurs initially when we are supine in late middle age, but later occurs erect, so venous admixture increases dramatically as we age. FRC falls with reduced lung or reduced chest wall compliance, and this is what we see in lung injury, where there's consolidation, pulmonary edema, fluid overload, abdominal compartment syndrome, etc. All of those result in loss of lung volumes or loss of functional residual capacity. This is strongly associated with hypoxemia. It's associated with increased shunt. It's associated with increased ventilation perfusion mismatch or venous admixture. It's associated with airway closure during tidal ventilation. It's associated with increased pulmonary vascular resistance and increased overall airway resistance. So what about Peadar, 67-year-old male, 5 days following esophagectomy, saturating 96% when sitting up but desaturation when he lies down? Well, there are lots of reasons why Peadar has become hypoxic. He would have had loss of FRC associated with anesthesia and surgery. There's compression atelectasis, there's absorptive atelectasis. This may persist when he's getting high flow oxygen therapy post-op. There's loss of FRC associated with aging. He's getting older, so lying flat he will have venous admixture. He may have loss of chest wall compliance associated with post-operative pleural effusions or even a pneumothorax. He'll have ventilation perfusion mismatch associated with airway secretions. This increases airway closure when he's lying flat, causing this VQ mismatch. There may also be a lot of dynamic airway collapse. So there's a lot to think about when you see a patient like Peadar who has low lung volumes, and he is best nursed in the head up or erect position. Let's review this tutorial. We covered a lot of ground in this tutorial. I started with a discussion about the macroscopic anatomy of the lungs. We discussed lung volumes in different positions, particularly looking at the different lobes. We discussed lung volume measurements and functional residual capacity and why FRC is so important, in particular with respect to closing volume, lung compliance, pulmonary vascular resistance, and pulmonary airway resistance. Finally, we discussed dynamic airway collapse. Next time, we're going to apply this information and see how CPAP and PEEP are used to recruit atelectatic lung units to treat the problem of phasic shunt. We will discuss the waterfall effect and the use of CPAP for heart failure. I'll see you then, and I guarantee you'll learn something. So that is functional residual capacity and low lung volumes. Next time we're going to talk about PEEP and CPAP. If you're finding these tutorials useful, don't forget to subscribe on YouTube or visit me at ccmtutorials.org.